Good evening, welcome. I'm Nora Kane, the director of the Stanford Health Library, and it's my pleasure to have you here this evening for actually our last talk, I think, on this spring calendar. And tonight's talk is on managing obesity in a meaningful way to create better health. I know it's a subject that's really important to a lot of people, and we talk about it a lot. And I think this is going to be an interesting discussion tonight with a two-part discussion featuring Dr. Dan Azagury, Associate Professor of Surgery at Stanford's Medical Center, and Dr. Michelle Hauser, Clinical Associate Professor of Medicine, General Surgery and Primary Care, and she's also a chef. So I think we're going to see a really well-rounded discussion of looking at a integrative approach to managing and talking about obesity. So just so you know that you are welcome to enter questions in the chat question and answer box. And at the end of the lecture part of this evening, the doctors will take the time to answer your questions. So without further ado, I'm going to turn this over now to Dr. Hauser. Thank you, Dr. Hauser, for being here.
Thanks so much, Nora, for that great introduction. I'll go ahead and start my slides here. Well, welcome everyone. Thanks so much for joining for this Stanford Health Library session on managing obesity in a meaningful way to create better health. It's a major focus that both Dr. Azagury and I have, and I hope you learn some new and interesting things that you might not have known about this topic as we go through the evening. And neither of us has any financial disclosures relevant to the topic tonight. And we'll have a few points at which we'll talk about our clinic and the different things that we do there. And just want to make it very clear that we are a big and multidisciplinary team with people with a variety of different types of expertise. And it really does take a village to help people really well manage weight and obesity, because there's many different aspects over the long term that need to be addressed. So here is our team. And before we get into a lot of depth about the topic, I just want to first start by defining obesity. And I think it's one of those things where a lot of people, think they know what it means, but then if you ask to define it, then it's a little bit trickier. So the complicated version is that it's a failure of normal weight and energy physiological regulatory mechanisms that leads to a body having excess fat mass. So we're not worried about extra lean mass, we're really worried about why there might be extra fat mass, and we call that a set point. And so a less complicated way of saying that is it's a medical condition where for whatever reason a body tries to hang on to more fat that would be healthy. And there are lots of reasons why that might happen. And another thing that comes up a lot that a lot of people have heard of, and they've heard the term BMI, but again, if I ask someone what it means, then it's relatively uncommon that someone can tell me exactly what it means. So since we'll bring this up again and again, I just want to define that. So basically, body mass index is a ratio of your weight to your height. And so it's weight in kilograms divided by your height in meters squared. And then when that number is 25 to just under 30, that's considered the overweight category. And then for 30 and above, there's some subcategories, but that's considered obesity. And that actually isn't, you can tell there's no measure of fat mass in there. So that actually isn't a great measure for an individual person, but it helps us classify people generally into risk categories. But the evaluation of whether a particular weight is a problem for someone health-wise is a much more detailed evaluation. And this is also not a very culturally sensitive definition or culturally inclusive definition. So depending on your ethnicity and descent, where your family is from, you may also have a tendency to carry weight more in the midsection, which is what causes more metabolic disease and more health problems. And so for people, for example, of Asian and South Asian descent, that tends to be the case. So they might actually start to have weight-related health problems at lower body mass indices than, say, the traditional obesity classification, which is really based on Caucasian population. So again, this is not a perfect definition, but it works in general. It's a good place to start. And then another thing that comes up pretty commonly is someone will tell me, oh, I've really always been athletic. I've lifted weights. I feel like I carry the amount of weight that I have okay. I'm not sure if it's a health problem for me or whether I should worry about it. And so when your body mass index falls in the 25 to 35 range, which is the overweight category and the lower end of the obesity category, then that's when it's a good time to get out the tape measure and really measure around the waist. And so like I was just saying, the weight that's in the midsection tends to be what causes the health problems and metabolic problems. So for men, if that number on the tape measure where you're measuring right above your hip bones, parallel with the floor, is 40 inches or above, and then it's a sign that you probably are at risk of certain health conditions related to your weight. And then for women, it's 35 and above. So that's a good way to help further classify people. And then I'm putting up this slide and I want to make it super clear that nothing on the slide is true. All of these things are false. So please, please, please don't take a look for a second at the slide and run away, because I really don't believe any of these things. So I just want to start out by sharing that there are a lot of common misconceptions about weight and obesity. And very, very sadly, almost all the patients that I have heard one of these things from one of their healthcare providers, most of which don't get a lot of training in obesity medicine or management of weight. So, I can't count the number of times I've heard calories in, calories out. If you just, ate less and exercise more, you would lose weight. Certainly that works for some people, and certainly that's an important part of any sort of treatment plan. But for a lot of people, that's not going to do it. And it's not going to be, a comprehensive enough way to approach weight management. And, other times I've heard that it's caused mostly by overeating or sedentary lifestyle. For someone who's predisposed to have obesity, those things certainly might make it worse or make it more difficult to treat. But there are plenty of people who, eat more than they should or exercise less than they should who don't have overweight or obesity. So it's not the only thing going on. I've also never encountered anyone who chose to have extra weight. And so it's really not a lifestyle choice. And I think there's a lot of times where people aren't necessarily getting a lot of good guidance or counseling because there's a bias that they're choosing to be a certain way. And that's also not the case for the most part. And then for people with quite a bit of excess weight, class 3 obesity, sometimes called severe obesity, that oftentimes it's not reversible by just voluntarily choosing to eat less and exercise more. And again, many patients avoid or never got offered treatment for their weight until they've had quite a bit of extra weight, because no one really thought that it was a problem or thought that there should be something offered early on. And that's also not the case. So again, none of this stuff is true. I just want to point out that these are a lot of the most common misconceptions I hear, and a lot of things that lead people to delays in care. So if you don't quite believe me, which I've definitely encountered when I'm teaching on this topic, then let me just walk you through a scenario where, let's just take an average adult. Most of us actually need about 1,300 calories a day to run our bodies. And most of us, that sounds really low because most of us eat a lot more than that. Most of us eat about 2,000 to 2,500 calories a day. And so that means that we're eating about 1.5 to 2 times the number of calories we actually need. But we're certainly not gaining 1 to 2 pounds a week every week like we would if we were actually absorbing all those extra calories. So what's happening? So that excess intake is really basically an evolutionary advantage, so that if you suddenly had some sort of urgent need to have more calories, that you're already accustomed to taking them in. So you become pregnant, you get hit by a car, whatever, you have basically some backup that you're going to be able to draw from so that you're not quickly losing weight. And if you have someone who's actually maintaining a normal amount of fat in the body to have a healthy weight, then that means that every day that their body is doing a really good job of getting rid of 40 to 50% of the calories that they eat. And what that means is that if between age 21 and 65, someone wanted to stay within a 20-pound weight range, that if you look at that based on what would have to happen for daily calories, that you'd have to be within 0.2% of the same number of calories every day on average, which means that you'd have to be within the calories of half a potato chip every day to keep your weight stable if you were doing it consciously. So if it was your choice. And what I hope is clear is that even for the people who are really, really incredibly gifted at keeping track of every single thing that they eat and and the calories those have, which I am not that person because I do not have that time, that even if you do that, you're not going to be able to keep track of it to that close of a degree. So there really are a lot of things going on that are outside of our control, and we'll talk about what some of those are. And a few other thought questions that hopefully get at that it's not just calories in, calories out, are that, we know that people on certain medications gain weight, but it's not that those medications have a bunch of calories. So what's going on there? What about the people who are gaining weight when they're stressed or when they're sleep deprived? Again, stress doesn't have calories, sleep deprivation doesn't have calories. So what's happening? And then there's also the more than 200 genes that have been discovered that if they're in a specific pattern, the letters that make up the DNA are in a specific pattern, that those people are going to have more likelihood of holding on to extra weight. And so again, genetics are very much outside of our control. But before I leave you thinking, oh, there's nothing I can do, everything's outside of my control, that's also not the case. So this is a complicated picture, but I hope I can make it clear that what we're looking at is, we'll say that this yellow line in the middle of the screen is considered what would be any one of our fat mass or set point. And that could be, that could be high, that could be low, it could be any point, it's just a generic number. And all the things above the line pointing up, all the arrows pointing up, those are all things that would tend to push the weight or set point that our bodies think we should be up to a higher number. So, you could imagine that someone might have started out with a set point that was in a healthy fat or weight range, but that, over years of having, certain medications that cause weight gain or sleep deprivation or a lot of stress or, a sedentary job, things like that, there's a lot of those things combined together can start to push up what weight your body thinks it should be trying to stay within, within this narrow range of. And then everything below are kind of the things that we can do to help give us a little hope here too, of getting that back into a healthy place. So everything above with arrows pointing down are things that tend to move the set point down. And so I'm just going to put in some colors here, which I use. I share this slide with patients in our program, in that, so through different parts of our program, we address each of the things that's circled. So almost all of these things are things that we can adjust, work on, have some medical intervention for. So we actually have a lot of tools at our disposal to help people with weight management. But it also emphasizes that it's a very complicated topic, and you have to address, you can't just pick one thing and address it and think it's going to fix the issue, just like heart disease, where you might try interventions and medications and lifestyle changes, that you're going to have to do that with obesity as well. So it's another complicated and long-term medical problem. And again, we're not just talking about someone's weight. So there are a lot of movements out there to be, healthy at any weight. Those are all great, great movements. And what we're really focusing on is not a weight or a number. It's really for people that, because of weight or, the amount of fat that's being stored in the body, that they're getting these other health problems, and they can affect any part of the body. So it's really something that can cause a lot of issues for your health, but also the same treatments can help all of these things at the same time as well. So there's a good and the bad side of the coin there. And then now I want to shift to talking a little bit about the center I mentioned, where we work to help people with obesity and overweight. So we're just renaming the center, and it will now be called the Stanford Lifestyle and Weight Management Center. And we have a few overall goals. And those include making sure that we're partnering with people to determine the best approach for each individual. Like all those things on the slide, we're not going to deal with 20 things at once. That would be really overwhelming if you came to the doctor and they wrote down 20 things you needed to change. So, over time, this is an overtime sort of thing that we work on, and we want to start with whatever's going to be most impactful and something that someone wants to change, and then, continue to move on down the line until we achieve an outcome that makes someone happy. And then we also want to make sure we're supportive and welcoming. So I like to point out that if shaming people for their weight ever helped with weight loss, then we would never have any patients. There's no one that comes to us who hasn't felt shame or bias or experienced negative outcomes or comments about their weight. So that's really not helpful. And so we want to do the opposite of that. And then we also want to emphasize that this is not a quick fix. So it's both not a quick fix, and it's not something that you fix and then move on from and never have to deal with again. So It does take time to achieve lasting weight loss. We're not aiming for quick weight loss and yo-yoing up and down. It's really to lose weight and maintain it in the long term. And like anything else, there's ups and downs. You have good times and bad times. And we tell people that, we definitely want to hear about your successes, but we really want to hear when things are hard, because that's when we can really be helpful. And so we really want to emphasize that to people. And we also do a lot of coordinating care with both the other disciplines in our clinic, but also many other medical specialties, because again, this is a condition that affects the whole body. So it's not just, you're not just going to come to one clinic and see, a couple people. You might be seeing a bunch of different people over time. And in our clinic itself, in our program, we offer a variety of things, some of which I have here on the slide. So like any weight management center, we obviously offer metabolic, or otherwise known as bariatric surgery, which Dr. Azagury will tell you about in a few minutes. And then for a non-surgeon physician who specializes in management of obesity and overweight, they're called a bariatrician. So we have a bariatrician-run medical weight loss program. And medical weight loss just means everything except surgery. So it's lifestyle changes, potentially medications, and addressing other medical problems related to weight. And then we have individual visits with both a bariatrician and dietitian. And then our dietitians have a whole bunch of different group programs, some of which are focused on rapid weight loss, because say someone needs to lose weight really quickly for a surgery that they need to have for a completely unrelated health problem. There's groups for preparing both before and recovering after from bariatric surgery. And then of course we have an intensive program focused on making lifestyle changes that are not just to see the numbers move on the scale again, but that are going to help someone be healthy in the long term. And so of the specialists that we're referring to, since I mentioned we coordinate with other specialties, here are some of the most common. So, first and foremost, if someone doesn't have a primary care provider, we really want to make sure they have someone that's, kind of being their advocate and, leading the charge for all their health problems when they're not seeing us. So we'll close the loop with that person. We do a lot of coordinated care with mental health, including psychology, psychiatry, behavioral medicine. And behavioral medicine is the part of psychology that focuses on behavior change for medical problems. So it's a little bit different than, going to a counselor or a therapist for, say, anxiety or depression. Most of our patients do have other mental health concerns like anxiety, depression, eating disorders. So that is something we spend a lot of time doing. Many people have sleep apnea, which is a condition that makes people quite likely to gain weight, that really they can do a lot better with management of weight if they're able to get tested and treated for sleep apnea. And then a variety of other places as well. I guess I want to highlight physical therapy, pain management, and physical medicine and rehabilitation. So we do have a lot of people that thought they couldn't exercise or couldn't do a lot of activity, and because of pain or other physical or mobility problems. So for most people, we can do something to treat those other conditions to help them be more active. So that's just a sampling of some of the things that we do. All right, and now you're probably wondering, how effective are these things? This is, after I've been talking for a few minutes, my patients always get answered. Just tell me what I can do and how it's going to work and how successful I'm going to be. So that's where we are, and I have these listed from most percent weight loss to least, but you shouldn't think of them as in isolation. It's not that anyone's going to do one of these things and then not have the opportunity to do something else. So the percentages of weight loss listed here are just for that individual item. So I will save talking about bariatric surgeries for Dr. Azagury, but in terms of how successful with weight loss people are, on average, if you take your starting weight, people would lose on average about 30 to 40% of their starting weight, which is about 60 to 70% of the extra weight that they would have above what's considered an ideal body weight. And then there are two main types of surgeries, which he'll explain to you, that are quite similarly effective. One maybe slightly more than the other, but both of those are quite effective treatments for weight management. And then we also have Dr. Esquivel in our clinic, who specializes in endoscopic procedures. So, no incisions on the outside of the body, but you can have an endoscopy, a scope going down the throat down into the stomach. And there's some different interventions, some of which are temporary, some are permanent, which can be done. And here are a couple examples and kind of the body mass index ranges that people would need to have to qualify for those. And then depending on the option, you can lose between 10 to 20% of your body weight. And this is all over about 12 months for everything listed here. And then for medications can be started at a lower weight than say a surgical procedure would be. And these medications that all help with weight loss can lead to about 5 to 15% weight loss combined with lifestyle interventions over about 6 to 12 months. And then for people that are really able to arrange their life where they're able to make a lot of substantial lifestyle changes and stick with them, I've definitely seen people get up in the above 20% weight loss. And again, most of these numbers are just averages. So there's always people that are going to do better and people who are not going to do quite as well. And then at the bottom is not because it's the least important, it's just the least invasive is intensive lifestyle changes. So everyone gets counseling on intensive lifestyle changes, which I'll talk about what that means in a second. But lifestyle changes alone without weight management medications or surgeries tend to, in the short term, 6 to 12 months, lead to about 7% total body weight loss. But there is a lot of weight regain if all you're doing are lifestyle changes. And so at about 1 to 4 years, people are only keeping off on average about 3 to 4% of their starting weight. So there's kind of everything in a nutshell on one slide. And now we'll talk about some details of each of these things. So who should consider each of these things? So for lifestyle interventions, they're pretty low risk. Anything we'd be recommending would be something that would also generally tend to make you at lower risk of things like heart disease and diabetes, joint pain. Many very common things would also be improved with these lifestyle interventions. And there's really not much risk to any of them. So they're really pretty much appropriate for anyone. But for someone who's aiming to do lifestyle changes to improve their health, then anyone with metabolic disease, like increased blood pressure, increased blood sugar levels, high cholesterol, risk factors, even family risk factors, say having a lot of people in your family with heart disease or who have extra weight. And if your body mass is starting to increase, those would be good times, especially to focus on this. And then what I mean by lifestyle interventions are things like diet and exercise, which everyone has heard about, but also a little more in-depth thinking about sleep and then level of stress, healthy relationships, mental health, making sure you have appropriate support, not just for your physical health, but for your mental health as well. And then if anyone is using substances in a way that's not healthy, then we want to address that as well, because that can affect not just weight, but general health, how good and functional someone feels, etc. And then since diet is one of the key things that we need to adjust to help with the initial weight loss, and I just mentioned a couple of things. Everyone asks, there's so much complicated diet information out there. One day butter is good for you, one day it's bad for you. What's the truth? What should I do? Some people say low fat diets, some people say low carb diets. I'm not sure what I'm even supposed to start with. So of the studies that look at diets that are helpful, and this is always dietary patterns. So things people are doing over over many years, this has nothing to do with going on and off a diet. We never really focus on going on and off diet short term or, yo-yoing in your weight. We want more of a steady weight loss, but most of the evidence-based diets that lead to weight loss, but also help with reducing risk of heart disease and other metabolic disease, have these 5 things in common. So eating plenty of fresh fruits and vegetables every day, very important. And that really gets you to point 2. So you get 2 for 1 there, that's what's going to lead to increasing fiber in your diet, which is important, not just to keep things moving, but for other things as well. And that's where you're getting a lot of your vitamins and minerals. Cutting out as much highly processed food as you can. And what I mean by highly processed food is, if you were to buy it at the store, it would have a long list of chemicals on the side of a box, things that you wouldn't, ingredients you wouldn't go to the grocery store and buy. You wouldn't go and buy monosodium glutamate or, some sort of sugar solids, something like that. So trying to limit as much as you can those sorts of foods, and a lot of those you would also be getting if you were getting a lot of prepared foods like takeout and deli foods from the grocery store. So that's where most of the salt in your diet is coming from. A lot of people will tell me, I do great at reducing my salt. I never use the salt shaker. And you're only getting about 10% of salt from a salt shaker if you're using a salt shaker. 90% of the salt that most of us eat is just in the food that we're getting already prepared. So that's actually where you want to focus to reduce salt in the diet. Highly processed grains, like things made with white flour and something that no longer looks like a grain. And then most of the added sugars and unhealthy fats are in processed food as well that we're eating. For proteins, trying to, if you're having red meat or other processed meats, trying to limit and cut back on those so that they're not the main source of the protein that you're getting. As much as you can, moving toward plant-based proteins, things like beans, nuts, tofu, and lean proteins like poultry, which is chicken and turkey, and fish and seafood. Moving toward those plant-based and leaner proteins are going to really be helpful, not just for weight loss because they tend to be lower calorie per gram of protein, but they're also going to be helpful for preventing heart disease and diabetes as well. And then last but very much not least is cutting out, and as much as you can, sugar sweetened beverages. So when you look at the side of a beverage, if it says there's calories in it, they're almost always from sugar, with a few exceptions like protein shakes or something. And as much as you can, cut those out. So when we have liquid calories like sugary drinks, then our bodies don't process those calories the same as they would solid food. They don't fill us up as much as the same calories in a solid piece of food. And they also tend to stimulate the appetite later in the day. Or, if you didn't go get food once your appetite was stimulated, that's when you have that afternoon crash. That's when you had sugar or a lot of highly processed carbs at lunch. And then, 2 o'clock in the afternoon, you feel like taking a nap. That's what's happening there. So that is really helpful to cut out. And so while we do spend some time talking about nutrition because it's important, another approach that I like to take around making diet changes is using something that's called culinary medicine. And for many people who probably haven't heard this term before, what culinary medicine is it's an evidence-based field that brings together nutrition and culinary knowledge and skills to help people, not just patients like it says, in maintaining health and preventing and treating disease. And this is in conjunction with appropriate medical care. It's not, we're not moving to a commune and doing this instead of medicine. This is a great support to anything else that we're trying to do. And what this is really focusing on is trying to not just talk about nutrition, but actually food. So how do we eat food? How do we enjoy food? If you can't enjoy food and share it with your family and friends over the long term, you're very unlikely to stick with whatever it is that you're doing for a diet. So this has become a pretty popular way to focus on diet and nutrition. So I tried to distill a lot of what I teach for people, especially in medical schools and health professional training programs, into a curriculum, which is at this link. You can download it for free. There's a bunch of materials and stuff about how you would teach, but there's also a lot of good nutrition information and some recipes. So feel free to download that. Again, totally free. There's no catch. You can have that if you want. And if you're curious about the topic. You can also use the lessons to teach your patients. So if you're a healthcare provider listening, there's a lot of, you can just take one session out of there and use it to teach in your clinic, which I definitely do with my patients. And then in the last few minutes here, I want to talk a little bit about what you would do beyond focusing on lifestyle changes. I know I didn't get to talk about sleep and physical activity. We'd have to have multiple hours to talk in detail about all of those things. But kind of moving on to the next more intensive type of treatment for weight management is adding in the medical piece. And so if someone comes, whether or not they've already tried lifestyle changes, then what do we do beyond that? And so we talked about the efficacy already of the combined approach, but what we're really focusing on in a medical and lifestyle weight management program is improving overall health, longevity, and well-being. So that you should actually feel better, not just have your weight being reduced. And we're also looking at reduction in medications for things that might be related to a weight condition. So oftentimes when people are losing weight and making healthy lifestyle changes, we're also reducing medications for diabetes or high blood pressure. and then also making sure to screen people for conditions that they might be at higher risk for having extra weight. So it's a pretty detailed and comprehensive approach to kind of overall health. And so we talked about who lifestyle interventions would be appropriate for. So the next step up, who would be appropriate for medical and lifestyle weight loss programs. So really anyone who is interested in non-surgical weight loss options, plus or minus weight management medications, which I'll get to in a second. If someone's planning to have bariatric surgery in the future, had bariatric surgery but didn't lose all the weight that they wanted, or they lost all the weight they wanted and at some point started to regain weight, someone who never wants bariatric surgery or does want it but isn't approved for some reason due to a health issue, and also someone who has enough weight that their outcomes with bariatric surgery would be better if they first lost weight. It's a pretty wide range of types of people that would benefit from this type of program. So that's who that's appropriate for, and what's included when someone comes. So I already covered most of this, so I don't want to be too repetitive, but basically we're looking at all the intensive lifestyle intervention factors, and then we're assessing for things like sleep apnea, fatty liver disease, diabetes, heart disease. We're looking at pain management for people that pain is getting in the way for their physical activity, checking in on sleep, seeing if they're getting enough, if it's restful, trying to treat any problems related to that, and then also making sure people are getting any sort of mental health and psychological barriers addressed. And then again, we're doing referrals to other specialists. So when we do prescribe medications in that context, then who could potentially get the medications? So, and I'm sure some people listening are wondering, I wonder if I should take a weight loss medication. So here's that piece. And so the quick answer is anyone with a body mass index of 27 or above could potentially have weight management medications. If you're between 27 and 30, it's recommended that you should only take them if you have some sort of health related problem related to your weight. So, high blood pressure, your cholesterol is going up, something like that. I don't run into too many people that don't have one of those things. I've never had to turn someone away for that, but anyone whose body mass index is 30 or above is certainly a candidate for weight loss medications. And very briefly, I'm not going to read everything on this slide, but just when I explain to people how they can be helpful, I like to mention that they're a tool to be used in combination with making healthy lifestyle changes. And what's really nice about them, in addition to just say making healthy lifestyle changes, is those changes take a while to do. And a lot of people have to trial and error what's going to work for them. They might try a diet change, it doesn't work. They might try a type of activity, they hate it and they don't want to do it, they want to try something else. So while you're figuring out what works for you for your lifestyle, the medications are giving you kind of an instant decrease in appetite so that you're able to start losing weight. And sometimes that's going to help you to do that increased amount of activity or be motivated to make those diet changes. So it's kind of some instant help with that. And then for the people that are going to tend to do best long-term, the people that eventually find those lifestyle changes that work and stick with them. Even if you don't, you'll probably lose some weight, but it's not going to be as much as if you're making lifestyle changes. And then there are, certain factors that we have to monitor why people are on medications. Usually things like blood pressure or blood sugar, if you're taking separate medicines for those things so that we can lower them to prevent low blood sugar or low blood pressure. Some that we have to monitor mood for some people, either it might improve or, we're more worried about if it, someone's mood is worse when they're losing weight or taking a medication. And then in terms of how we pick which medicine that we would give to someone, it's usually a lot of the weight loss medications are actually things that have been used for other medical conditions in the past. And so often we're picking something that's also going to treat something else someone already has. So it's kind of two birds, one stone sort of scenario. And otherwise, if that's not the case, we're also trying to make sure we minimize any adverse effects. So not giving someone something they shouldn't have because of a medical condition they have, not giving something that interacts with another medication they take, etc. And then the last thing before I turn it over to Dr. Azagury is just to not to scare you off with a bunch of unpronounceable drug names, but just to list the medications that are out there for weight management. And so, this would be, if you're curious about it, you can take a screenshot and look them up a bit. Everything above that first line in the middle of the slide is approved for long-term use. So, you know, if I tell patients, usually I recommend it taking at least a year, because once you lose weight, you want to stay on it to stabilize your weight for several months so that you're not as likely to regain the weight once you stop the medicine. But I have some people that stay on them for many years, and they really need to do that to keep off the weight. And then there are a few other things that I have in the middle that we can use if someone can't take or needs something in addition to one of the long-term medications above. And then there's other things for short-term use, which we use a little less often. But I wish I had time to go through each one of them in detail, but just know that there are lots of options out there. So if you thought that there was an option for you, or you tried one thing and it didn't work, there's probably something else out there that's possible to try. And whether or not it's appropriate for you, you really need a pretty detailed medical evaluation for. All right, so I'm going to stop there. We'll save questions for the end, and I'll turn it over to Dr. Azagury to talk to you about metabolic surgery.
Thank you, Dr. Hauser, and thank you for the invitation to share some of our insights. And I see that there's already a question. We'll get to the questions at the end so that you have a full view of what we're trying to share. I would say this is a really exciting time in terms of managing this disease. And it's an exciting time because of the environment in general and the new possibilities and therapies that are coming or that are here. And it's an exciting time at Stanford because we're really in this multidisciplinary clinic that is an extension and a novel approach to managing obesity, everything under one roof, whether it is surgery or whether it is a dietary approach, medications. Everything happens within our clinic, and a few centers across the country are offering that, and we're really happy to be able to offer that to our patients here at Stanford. So to talk a little bit about the surgical aspects of weight loss, this is essentially a therapy that is, I would say, one level or two more effective, and also a little bit more aggressive in the sense that it is a surgery. Even though these are surgeries with very low rates of complications that are performed laparoscopically, it is a surgery. And if you look at what Dr. Hauser presented, you really go up from the dietary recommendations and lifestyle modifications to medications to surgery, just like you would for any other disease. And looking at the BMI, again, it's an imperfect measurement, but it gives a sense of where you are on the severity of obesity. It doesn't paint the whole picture by any means, and it has many flaws, but this is still the marker by which insurance companies go and decide what treatment a patient will qualify for. So for surgery, it would be a BMI greater than 35 if you have any conditions associated with obesity, such as hypertension, sleep apnea, diabetes. If you have a poorly controlled diabetes, some insurance companies will cover a surgery at a lower BMI between 30 to 35. And if you have a BMI greater than 40, even without any complication, then or associated illness, then you would qualify for surgery. The bariatric procedures that we offer at Stanford, as Dr. Hauser alluded to, are both laparoscopic surgeries, and all of my partners and myself perform these routinely. And this is our area of expertise. This is what we do day in, day out. And we discuss with each patient individually which surgery is best for each patient individually. And I think that's a big portion of what would happen at a first encounter with a surgeon, is really determining which procedure would be best for you specifically. The Roux-en-Y gastric bypass is a little bit more involved. It entails cutting the stomach to the size of a small egg and cutting the intestines and rerouting them so that they're connected directly to that small little stomach. The bypass is on the left of the screen, and the food goes where the arrows are and flows down directly into the intestine, bypassing the portion of your intestine and stomach. The sleeve involves only a component on the stomach, and it involves eliminating and taking out a portion of the stomach. Your stomach is about the size of a football, and we narrow it down essentially to the size of a banana. And so these two surgeries, besides the sheer component of reducing the size of the stomach, they have many more aspects to them, including a hormonal aspect. The drugs that Dr. Hauser alluded to, and I said it's an exciting time because we have had over the past 5 to 10 years, finally some effective drugs to fight obesity that have been approved by the FDA, including one very recently, which is very effective and was discovered because of the gastric bypass. When we identified that the bypass had some hormonal effects, some very smart people started to analyze how that was happening and identify some hormones that were increased after the gastric bypass. And 2 decades later, we have a drug that mimics that effect and has shown to be able to help patients lose a significant amount of weight, such as the semaglutide. So how do we choose? This is a very bare little diagram to give you a little bit of a sense. These surgeries, as I mentioned, are performed laparoscopically, so it's 5 little incisions. You can go home typically the next day after these procedures, and they're both good in terms of treating diabetes. If patients have a BMI that is greater than 50, usually a single strategy is often not enough, and we'll talk a little bit about that. That's the beauty of having a multidisciplinary strategy. We will, just like for other therapies, for other diseases, we will combine therapies to be as effective as possible, and we kind of up the regimen progressively and until we get to the right treatment for each patient. If you have acid reflux, that's the one thing that is a little bit of a contraindication for the sleeve. Most patients can return to work within a couple of weeks. So on the next slide, this is the part about combining strategies. As I just mentioned, just like any other disease, sometimes you need multiple therapies to get to the and managing the disease appropriately. And the BMI of the patient is starting above 50 or 60. Before surgery, we will start with a medical weight loss program. We will start with all the things that Dr. Hauser has explained. And once we've essentially maxed out on those initial therapies, then we will move on to a surgery. How risky are these procedures? This is a little bit of an older report, and if anything, things tend to improve in terms of complications. But you can see that if you compare our data to the rest of the academic centers in the country and the rest of the weight loss centers in the country, we have excellent outcomes. And you can see that out of the number of surgeries that we did, the number of complications are between 0 and 1 out of a total of about 300 between the gastric bypass and the sleeve gastrectomy. So complications are rare. They are possible. It's still a surgery, but complications are infrequent. How much weight do you lose? Similar to what Dr. Hauser explained for medications, there is a higher risk profile, but there's also more effectiveness. And so on average, patients will lose about 16 to 17 BMI points with a gastric bypass and about 13 to 14 with a sleeve gastrectomy on the right. And again, this is an average. So obviously this is, some patients will fall on one end or the other of that average. Well, does it work in the long run? And the advantage is that the gastric bypass has been around since the 70s. And so we have really good long-term data. We have patients who have had these surgeries 10, 20, and even 30, 40 years ago. And so this is an analysis of patients who had a gastric bypass and were followed for 15 years. You can see that that percentage that Dr. Hauser was talking about 50 to 60% of the excess weight that you lose after the surgery. So this is year 1. So it's yours on the bottom. And you can see that at year 1, thank you, Michelle. At year 1, people lose weight very quickly. It tends to stabilize between year 1 and 2. And then it goes up a little bit. Patients tend to regain a little bit of weight, but it stabilizes around that 50-55% excess weight loss mark. And it stays about the same for decades after that. So it's very effective. It is a long-term therapy, and the efficacy is maintained in the long term. And there are a lot more advantages than the weight loss itself. As Dr. Hauser, the effects of this disease have impact on multiple aspects, whether it's cancer, diabetes, cardiovascular disease. But the good news, as Dr. Hauser mentioned, is that when you treat obesity, the impact on your health improves as well. This is a very, very well done study where they looked at 10,000 patients who had a gastric bypass, and they compared them to 10,000 patients who had the same height and the same weight based on their driver's license. Now, it's not perfect, but what they saw is that over a period of only years, so don't wait 20, 30 years to see the effects of the surgery, the risk of dying from any condition goes down by 40%. The risk of developing, of dying because of a diabetes-related death is essentially cut in half. It's down by 92%. Sorry, it's down 92%, and the risk of cardiovascular diseases is cut in half. So really very meaningful impacts in terms of how long people live and what people die from. Same thing on a more granular level, the improvements of what we call these comorbidities, so the diseases that are typically associated with obesity, are really impressive after these surgeries. And so if you look at the last 2 columns, which is improved and resolved, and you add them, for example, if you have high cholesterol, in 63% of patients, it's completely resolved, and you add another 33% in which they're improved. So it's about 99% of patients will see either an improvement or resolution of their high cholesterol. Same thing for hypertension is about 88%. Sleep apnea is about the same number. And then for diabetes, it's essentially 100% if you add the 2 numbers of people who will either be completely, we don't say cured, we say that the diabetes essentially is in remission, meaning that your hemoglobin A1C, your marker of diabetes, is normal or within an ideal range, and you don't need any medications anymore. So really meaningful impact on patients with diabetes. So just like we talked about for the other therapies, this is not a one-time and done therapy. It requires some lifelong follow-up in order to not let the weight kind of creep back up over time. And so again, this is one of the benefits of our clinic, is that after these surgeries, you will have some periods where things are a little bit more challenging, where patients have life events, diseases, reasons for which things will get under more stress, and patients will tend to regain some weight. And so the goal is for us to provide further tools and combine these tools of surgery and lifestyle change and medications, so that in the long run, patients are successful and can keep the weight off. A quick word on what the postoperative management looks like, and will be done soon. It requires a little bit of management after surgery, taking multivitamins once a day. We like to see our patients in the long run, so we see them 4 times the first year, and then every year after that, to see how they're doing. Essentially, that's I think my last slide. Yes, that was my last slide. So hopefully Dr. Hauser and I have given you a broad overview of what our clinic has to offer, and also what some hopefully positive and encouraging news around the management of this widespread disease, which is obesity, and this multifaceted disease. So we welcome any questions, and thank you for your attention. I think the first question is for you about what is an off-label medication.
All right, so what are off-label medications? That's a great question, and I figured we'd talk more about the medications in the Q&A. So off-label medication is not anything specific to obesity. So it's really whenever you're using a medication that we know as medical providers has a specific effect, but it might not be approved, mainly because it hasn't had a really good randomized controlled trial to look specifically at the effect of that medication. But so a couple of examples are all the medicines I had listed at the top, which are approved for management of weight. Basically, most of those are, or half of those are combo medications. So they have 2 drugs in 1 pill. And that's basically an example of a pharma company taking 2 things that were used for something else and found over time that people that took those medicines lost weight, and then saying, oh, well, we can make a new product out of this and sell it. So they combine it into something else, do a study on it, say, look, it works great for weight loss, but everyone kind of already knew that, but it does quantify how much weight together those drugs can help someone lose. But let's say one of the combo drugs, you could take one of the medications in it, but not the other. And so sometimes, actually very, very often, I'll prescribe the one that someone could have without the one that they can't have. So it's just basically splitting apart the combo pill. And then there's some other medications that, aren't part of a weight loss drug, but we know, again, that they're just really good for weight loss, or they're good for a little bit of weight loss. So they're not great on their own, but we can add them on if someone hits a plateau and they need a little more help getting to their goal weight. All right. And then, another medication question. All right, so I can go ahead and do this. So the name of the recently approved medication, the brand name I actually just learned today, which is kind of funny. I'm not even sure if I'm saying it right, but it's Wegovy. I'm sure maybe there's some better pronunciation, but the generic, which is what I'm used to, is semaglutide. And it's actually a drug that's been available for quite a while for diabetes. So it's, if you're worried, oh, I don't want to be the guinea pig, I don't want to be the person that takes the new medication. It's actually, I've been giving it to people for diabetes for years. It's great. And it helps almost all of them lose weight. And this is basically taking that medication, because we've all seen that it's great at helping people lose weight and control their blood sugar. And then they're testing it like similar medications in the same class or the same group of medications, testing it at higher and higher doses to find out, well, how much can we give someone before where they're having good amount of weight loss, but that they're not getting intolerable side effects. So it's more than twice as much as we would typically give for diabetes. And you actually don't have to have diabetes to take it. So it doesn't cause low blood sugar in people that don't have diabetes, but it does help with blood sugar management in people who do. So it sounds too good to be true, but it actually does really work well. It also can help prevent certain types of cardiovascular disease and maybe treat other conditions as well. So that's kind of the least risky, best side effect profile medication we have. And there's a couple that cause weight loss that work similarly, but they're really nice because they have other health benefits. So
I'll add. Just
I promise I'm not a drug company shill. I don't get any money for that.
None of us get a kickback out of this.
Yeah, no.
I think we're both very enthusiastic in the sense that, I think to Michelle's point, it's not too good to be true. It's been very, very. It's been a very long time to get here. This is one of the most prevalent diseases in this country and in the world, and we've had a complete lack of available effective medications to tackle this. And so it's been decades in the making to get to this point. There is a cost downside still to it. And at this point, the FDA has approved it, but it's not yet reimbursed. So don't expect to be able to obtain that at the pharmacy just yet. But it is very exciting for us to finally have some therapies that are non-surgical therapies.
And I don't see other questions, but I just want to kind of jump off
write
what
it in the chat. I'll put it in there for someone with no insurance, what would you all recommend as first step to try to lose if your BMI is greater than 40? So first steps to lose weight if your BMI is greater than 40 and you have no insurance. We are working on, oh, thank you. Dr. Hauser is typing the other answer. So we're working on revamping. It's going to take us a few months, but we're working on revamping our website to offer some guidance and some tips and things like that that you can find on our website. Dr. Hauser's book is available for free, as she mentioned. So you can download that and start to implement some of the recommendations that are there. My biggest recommendation would be, this is the right time to get insurance. Insurance rates have gone down in California thanks to the federal incentives. At this point, I don't think it's ever been cheaper to get insurance, and you can get, I think it's still open till, I don't remember when, but it's there's an open enrollment period that's still going on now. And with that, you can come to see us and we can prescribe medications. And that would be my biggest recommendation.
Yeah, and I think in addition to that, I do see a lot of patients who have county insurance, or Medi-Cal is the Medicaid version of insurance in California, and so those programs do actually cover some of the weight loss medications. And so there's not anyone I've encountered for which they have drug coverage that covers zero of the medication. Sometimes they're not covering the brand name combo pills, but they'll cover the old versions of the drugs prescribed separately, as giving you both off-label versions that would be effectively the combo pill. So usually there's some way around that to make it pretty inexpensive. And even for people that need to cash pay for some of the medications, there's coupons and things that make them really inexpensive. So there's usually a way to make it, if you can get to the doctor's appointment, there's usually a way to make it pretty affordable.
And then, do you facilitate study groups and online services? I think we can both take a little bit of stab at that. Michelle, do you want to go first?
Oh, sure. And so almost everything we're doing is on video right now. I think a rule for private insurance usually in any state is that you have to be within the state to get virtual care for the person. The person you're seeing has to have a license in the state that you're physically located in. But we can see someone in LA, even though we're up in Palo Alto, virtually, and prescribe medications and treatments. Obviously, Dr. Azagury can't do surgery remotely, but almost everything else can be done remotely.
And I think, and if you meant certain kind of free online tools potentially, again, we're kind of working on that to help provide some on our website. I'm going to say it's probably going to be about 6 months till we have some of those, but our goal is to provide some tips on our website. The study groups or the med groups are under, you have to be one of our patients for us to be able to see you, but yes, that is done virtually. And so you can join that. If the only thing you need is a referral to our clinic from your PCP, and then we can take it from there.
And I don't have a lot on my website, but I also have some, example sessions of things we might talk through for, basic diet, physical activity education, things like that. And it's chefandmedicine.com. But I can't answer medical questions or anything on there. So it's there if you want to watch it there or on YouTube, but to actually get feedback and get personalized recommendations, yeah, you do need to see a professional for that.
I think that might be all of the questions that we have for this evening. I want to thank you both for your wonderful participation. This was a really illuminating experience. I love the well-roundedness of approaching this problem, which is, as you pointed out, enormously complicated and not a one-size-fits-all kind of solution. And I think for the audience tonight, there was a lot of subject there for us to really think about and to act upon. So thank you very much. We appreciate you being with us. And for the home audience, thank you for tuning in. And remember, if you wanted to watch this again, it will be on YouTube in a couple of weeks. And we hope that you'll share the link with friends. And otherwise, go forth and have a good evening. Thank you very much.
Thank you.
Thanks everyone for joining.